South Texas Regional Family Medicine Grand Rounds. Next slide, please. So here's the activity code for today, so you can all claim your CME credit. I'll leave this up here for a bit so you can all do that. All right, next slide, please. This is just information regarding the AAFP credit system. Next slide, please. And these are the core competencies that the grand rounds will address today. Next slide, please. And now we have a brief introduction from Dr. Obaid.
I am very excited to introduce a colleague and friend of mine, Dr. Corso, here with us presenting on PROSPER, Proactive Reduction of Suicide of Populations via Evidence-Based Research. I do want to tell you a little bit about Dr. Corso before we get started. He is a licensed psychologist and board-certified behavior analyst. His career in suicidology began over 20 years ago while serving in the U.S. Air Force. Dr. Corso has researched, developed, and evaluated suicide prevention programs across North America, Europe, Australia, and Asia. Most recently, he developed PROSPER, an evidence-based suicide prevention and intervention program. Dr. Corso has published over 50 peer-reviewed papers on suicide and the behavioral sciences, and is a leading expert in novel scientific methods and digital technologies for analyzing suicide. He also, it's not in his bio, but he is a primary care expert and guru as well. But without further ado, I will hand it over to Dr. Corso.
Thank you so much, Stacy. Really appreciate the warm introduction. I thought you were going to leave the detail that I used to be a bartender, which does not have relevance to this topic, nor is it necessarily a positive spin or background when dealing with suicidal individuals. But I'll take the PCBH, the primary care behavioral health one too. So thank you.
Yes.
Really grateful to be here with you all. We'll dive right in here, our learning objectives. By the conclusion of this activity, learners will be able to explain how suicide is a social problem, not simply a mental health one. Learn to analyze patterns and styles of helping that have unintended negative consequences and do not reduce suicide in communities longitudinally. And then learn how to apply evidence-based ways of reducing suicide risk to their current practice habits. Before we dive in, I just want to explain that PROSPER is the integration of all the evidence-based literature out there. I'll put this question in the chat box. I see at least one person who's attending driving, so please do not comment in the chat box. If you are driving, please be safe, safety first. But the first question is, how many patients with suicidal symptoms have you seen before? And you can put any number in the chat box there. And while you're entering that number, I just wanted to explain that on average, as you probably know, it takes about 17 years for research to get to the deck plate where clinicians can practice. That's the average across all different specialties, from pulmonology to primary care, what have you. With suicide research, it takes more like 30 years. So the gap between research and practice, that is the reason we have translational medicine and translational projects that try to get the research in that applied setting quicker. On average, it takes 30 years for suicide research to get from research to practice. And so part of the purpose of PROSPER is to scour the literature and make sure that we are culling it for information that is very applicable to try to shore up that gap for clinicians. So just want to explain that briefly. I'm seeing in the chat box the range of patients we've seen is between more than one can count, which is great, almost all, over 10, all the way down to one. So a range of experiences there, and that's pretty important. One other thing I'd like to sort of drop in the chat box as we're beginning is, what's your confidence level managing these patients? Would you say it is low, medium, or high? What's your confidence managing these patients? Low, medium, or high? Okay, mostly medium, maybe one or two lows. And don't be shy. This is a safe place. This isn't going anywhere. Doesn't go on your training record. No preceptors. Actually, if they're on here, they have already agreed with me privately to not say anything. So no shame here. Okay, and then so that's your confidence. But what's your comfort? Sometimes we're confident we're doing the right thing, but we're not very comfortable doing that thing. Whoops. Okay, so with comfort, it looks a bit lower, although there are also some on the higher end. Okay, we will. Hey, Cindy, great. Cindy's here as well. We will come back to that
Ma'am, hi, Ken.
at the end. Just for those of you who care, Cindy was one of my trainers back when I was a resident.
Okay,
That is
nice to
not a
meet you.
statement about her age, but rather how seasoned she is as a clinician. So just
That
want to be
was
clear.
that was pretty good. That was smooth. I appreciate that, Ken. It's wonderful to see
I'm digging.
you.
Oh, good to see you too, Cindy. I'm digging. I'm going to try to stop digging now and just move on. Um, so as we talk about the material today, one of the things we'd like you to keep in mind is to try to apply this information in three ways. Certainly apply it within the context of being a clinician with the people you work with, but also apply it in the context of your personal life. So family, friends, coworkers, and then apply it to yourself. Do you think that most people who go into a suicidal crisis in advance thought, 5 or 10 years from now, I'll have a rough period of life and I'll just think of killing myself? Of course, they don't, right? So, what it means is this doesn't discriminate. It can happen to obviously almost anyone. And if we're waiting to address suicide simply in the ER or through first responders or even in the medical clinics, we are probably not going to bend the curve. We've got to get upstream. And certainly, primary care is one of those upstream locations in our system. But the other place is really acting in our personal lives, taking the time to think about our friends and family, our coworkers, and then, of course, ourselves and our patients. So, pretty high level, we're going to have a frank conversation today. If you do have any lived experience, if you're triggered, please take care of yourself first. It's sort of like what they say on the airplanes. If you don't put on your oxygen mask first, you really can't do anything else. So please do take that time and honor your experience. High level, suicide's a social issue. 12.3 million adults have considered it annually. The most recent research is actually 12.4 million. So these data are from 2022. The 2023 data are slightly higher. So 12.3 million think about it every year, 1.7 attempt, but about 48,000 die by suicide. What are the light bulbs that go on as you think of these ratios? 12.3 million think about it every year, 1.7 attempt, and 48,000 die by suicide. What comes to mind? This is the audience participation part.
Comes to mind that it's sad.
Thank you, Brooklyn. So it comes to mind that it's sad. Anna in the chat box says it's a lot. Mary says it's very common. And I think all of those are very true statements. 12.3 million is probably an underestimate. And as Ellie points out, most of those who think about it will not die by suicide. In fact, of those who think about it, 13% will attempt, and less than 1% will die by it. Angel points out that she considers how many providers may have seen the person and didn't intervene. So that's a great comment, Angel. There's some studies that show that 58% of adults who die by suicide have no mental health condition whatsoever. There's another recent study from 2022 showing that if we could fix, and I'm going to use air quotes there because we might have different ideas about how to fix the mental health system. So if we could fix the mental health system, that would reduce suicides by only 20%. So when we think about this, the important take-home messages are all the things you've just mentioned. But in addition, it's a lot more common than you'd think. And one of the reasons why we don't realize it's so common is because we don't talk about it. I can't remember the last time I went to a academic function or a cocktail party, and the first thing someone said is, "Hi, my name's Bob. I'm a suicide attempt survivor." Or I was thinking of suicide last week. I mean, honestly, it's a Debbie Downer. It's not the kind of thing we typically think about. And so because we don't talk about it, uh, we tend to think it's rare. It is technically, when we look at the statistics, a low base rate phenomenon. And yet it's still among the top 10 causes of death for adults and the number 2 cause of death for children and adolescents ages 10 to 17. So, without boring you with statistics, 2002 suicides were the highest they've been in American history. As you probably know, there's a lag time of about 3 years in crunching the suicide data. So the CDC may release every year or so the preliminary stats from that prior year, but they only have the most confidence after 3 years. And so these are the most recent data we can look at. Youth suicide is on the rise. We're seeing the largest increase in the 12 to 14 age group, and after that, the 15 to 17, and then the 5 to 11. To be honest, we don't see many suicides under age 10. Does anyone know why? We definitely see suicide attempts and we see hospitalizations for suicidal ideation, but we don't see many deaths by suicide under age 10. The reason why is because we typically don't leave 5, 6, 7, 8-year-olds unsupervised for a long time. Also, as Brooklyn points out, they may not know how to execute an attempt. Their executive functioning is generally underdeveloped, right? We know that the frontal lobe is not really finished developing till our mid-20s. So that's part of the puzzle. We'll come back to this once or twice today, and it's really important when we think about applying suicide risk reductive measures to our own lives, is that people don't usually kill themselves in front of others. People don't usually kill themselves in front of others. There's something about the accountability of someone else present that makes someone unlikely to do it. Now, obviously, we can't speak in absolute terms. There are situations where people will sort of weaponize their suicide. And let's say a pretty abusive or toxic or intense relationship where someone kills themselves in front of their intimate partner in order to sort of spite them or get back at them. But again, that's a very small percentage of the cases. By and large, people don't kill themselves in front of others. Also, some important population differences here. Obviously, indigenous populations have the highest rates, and that's not surprising considering a near genocide historically. They have the highest rate even compared to other communities of color. African American females ages 12 to 17 are actually the fastest growing cohort of individuals dying by suicide in our country right now. And again, the girls more than boys. Also, those among disabilities are 3 times more likely to report suicidal ideation. Even the presence of mental distress alone puts people at higher risk when they have disabilities. Consider that with many disabilities, there are communication differences, interpersonal differences, difficulties accessing just general health care. That makes this population another special one. Similarly, the ASD population, autism spectrum, they've got 3.75 times higher rate compared to typically developing individuals. And when we look at what drives that, it's typically the higher functioning folks with autism. And it's thought to be a combination of poor access to healthcare and social isolation. So again, I think when we think of the classic poster child for suicide, it's the 46 to 64-year-old or 46 to 68-year-old white male who owns a firearm. And while that might be the poster child, profiling doesn't really get us anywhere. And if we're not looking for the underlying common denominators and drivers of suicide risk, we're really not going to bend the curve. So signs and symptoms, you all know what these are. Talking about suicide, talking about ending your life, talking about a foreshortened future, giving away items, getting your affairs in order. You all know this stuff. You know that if you're doing a PHQ-9 and they answer, they endorse that ninth question about being thinking about ending their life or harming themselves, that's something we should act on. When we look at the triggers, that is the psychosocial factors immediately preceding a suicide, they really haven't changed in 50 years. We'll start at the top here. 42% of suicides are preceded by a relationship problem. Then we have alcohol and substance use. We have financial problems. Down here on the left, we have homelessness and housing problems. Here we have problems with self-identity and self-image. When we move down to the right bottom, we have legal problems. Over here, a chronic illness. We know chronic pain, insomnia are independent risk factors for suicide. Up here on the top right, we have any crisis that is sort of impending or may have happened in the last 2 weeks. And then finally, we have social isolation. When you look at all of these factors, there are two that sort of bubble up to the top as a component of all the others. Does anyone know what the common denominator is among all these triggers for suicide or these precursor stressors for suicide? Okay, I'm spoiler alert. Oh, they don't know how to successfully deal with stress, hopelessness, isolation. Yep, you're getting there. Depression, you're getting there. So whether I've lost my job, whether my marriage is over, whether I am financially strapped, all of those tend to somehow negatively impact my self identity and my meaning and purpose in life. So when people wake up in the morning, and so please consider this in your own life for yourself. If you wake up in the morning sometime and you roll over in bed and say, why would I bother to get out of bed this morning? I have nothing to live for. I really don't have a purpose here, or I don't know who I am anymore. I used to know who I was. Um, all of those sort of existential issues, that's the precursor mindset to suicide. So really important not to profile people by psychosocial stressor, but rather to focus on the impact of that to their sense of self. Um, and let's remember that 80% of people who die by suicide will show some sign or symptom, 20% will not. So, um, there's some thought out there that somehow we're going to eliminate suicide, and the research just doesn't support that. Statistics don't support that. At best, we can reduce suicides by about 80%. The 20% who aren't showing signs are comprised of two subgroups. The first subgroup escalates so quickly that there's no time to intervene. The second subgroup of that 20% are determined to die. And so they conceal their symptoms. If we screen them or ask them about it in our personal lives, they'll deny it. They'll say, nope, I'm doing fine, or I'm just having a bad day. And so let's put all our efforts into sort of approaching that 80% and then throw all our R&D dollars into figuring out how to help that 20%. That's a much more precise way from a system perspective to work on suicide risk reduction versus some hyperbolic goal of getting to zero. There's also this myth, and I know we've probably all talked about this, that if we talk to someone in our personal lives about suicide, we might make them more suicidal. I have heard PCPs talk about that as well in my time in primary care, that they're kind of nervous to ask a patient, especially if the patient has sort of doorknobbed them and this is the end of the appointment. And now they say, hey, by the way, I'm thinking of killing myself. The PCP is sort of disarmed, so to speak. There's no evidence that asking someone about it will make it worse, but there is some evidence that if we don't ask, we might make it worse. So, for example, when we talk to people who have attempted suicide and lived, and we say, what was life like in those 2 weeks before you tried to kill yourself? They'll say, it was horrible. I was not performing at work or school. I was not taking care of myself. I wasn't eating. I wasn't sleeping. I wasn't bathing. Everybody around me knew that there was something wrong. and not one person asked me if it was okay. And you know what that made me think is maybe I should do it because I don't matter. And if I did matter, people would be asking me if I'm okay. Therefore, I must be worthless because they're not asking. And it's really sad because our reticence to ask is not because we want to see them die. It's because it's an awkward conversation, especially if it's in our personal lives. Um, in a medical setting, especially if maybe we're practicing in a rural setting, we may not have the resources to treat this. So we're not going to go fishing for clinical problems that we can't reel in our boat, so to speak. So again, as you think about this in your personal life as well as your clinical world, not saying anything may unintentionally make it worse. Now, let's be clear. We can't own someone else's behavior. When someone chooses to end his or her life or their life, that's on them and they own that behavior. But we do own the opportunities to, in some way, try to be a part of the solution. Shifting to a more clinical part of the discussion, there's something called the suicidal mode. I'm sure you've all heard the ideas passive SI and active SI. Could you put a yes or no in the chat box if you've heard of active suicidal ideation and passive suicidal ideation? I'm seeing lots of yeses, one or two nos. Okay, so really important piece here. It's less helpful to think of it in terms of passive and active SI. And the reason why is because I can't observe a thought happening, whether it's active or passive, and I don't really know how to operationalize a passive thought. And so because it's less observable and thoughts are happening all the time, a more valid and reliable way to look at suicide is this suicidal mode. And that's this state of mind where someone's thinking of killing themselves while also having this flood of negative emotions, negative thoughts. There are also behavioral sequelae like withdrawal or substance use or not taking care of oneself. There are also physiological sequelae like having the fight or flight response kicked in. Sometimes they may have another medical or physiological issue going on. Sometimes there's substance use like chain smoking or drinking or excessive nicotine or caffeine. And so it's this sort of state of mind where we're typically taught that the person's mental status is somehow compromised, right? So we talk about the suicidal mode being on or being off. And I think we can all think of a time we've seen a patient or maybe even a friend or family member where they were in crisis. And that moment where they're not making a lot of sense, it's not that they're psychotic, it's that their mind is racing, they're in this moment of despair and desperation. That's the suicidal mode being on. Now, the reason why this is important is because we want to work differently with people based on whether their suicidal mode is on or off. And that's because their mental status is sort of intact or less than intact. So, for example, if I am just a person and I wake up in the morning and I roll over in bed and say, "Oh, why would I bother getting out of bed today? I have nothing to live for. I think today's the day I might kill myself." And then I get up and I get in the shower and I brush my teeth and not in that order necessarily. And I start getting dressed. And I still am thinking to myself, maybe today's the day I'll do it. I've planned it, I've prepared, I've rehearsed, I know exactly how I'm going to do it. And as I'm leaving the house to go to work, I think, you know what, maybe I'll call my PCP and see if they have a walk-in appointment. Maybe I'll give this living thing one last ditch effort. And so I call the clinic and of course it's a great clinic. And they say, sure, we can give you a walk-in appointment. How does 11 o'clock sound? And I say, great. 11 o'clock works for me. I hang up the phone, I go to work. When I show up at the clinic at 11 and I get in the room with the nurse or the tech or the doc, they say, so how can I help you? Say, I'm thinking of killing myself. As that clinician, I want to know, are you thinking about it right now? In other words, is your suicidal mode on right now? Or did you think about it at 7 a.m. and that's why you're here today? There's an enormous difference between someone who thought about it at 7 a.m., then packed those thoughts up and went to work, and now it's 11 a.m. and they're coming in to sort of get help. Give me a yes or no if in the chat box if you're tracking with me, if that resonates at all. So it's good. So great. I'm seeing that we're together. It's really important to ask that, and they may not know what the suicidal mode is. So a good question to ask is, when's the last time you had these thoughts? And they may say, well, it's when I made the appointment this morning. That's good news because likely their mental status is intact, which means we can do everything we'd want to do with someone to help educate them with psychoeducation, to empower them, help them understand the cost, benefits, and alternatives of any number of treatment decisions. Okay. It also means that their assessment, when we ask them, let's say, a Columbia suicide severity rating scale or some other type of interview, it means it's likely to be accurate. Another piece to the puzzle here, and if you haven't guessed, I'm sort of starting with some of the things that haven't been working for the last half century. We can't predict future suicides. So if you take a moment and just imagine the last time you were with a suicidal individual, or all the times you've seen someone in suicidal distress or crisis, what's that question that's sort of nagging you in the back of your mind as you're going through the interview or you're doing whatever protocol the clinic requires? What is that question you have in the back of your mind? Well, we all come from different walks of life. We tend to be wondering the same thing, and we sort of inherently start asking questions to try to ascertain this answer. Okay, Liliana says, what's the patient going through? Great. Anyone else? Will they attempt? That's great, Ray. Thank you. Is the patient telling the truth? Umadevi, thank you. And by the way, if I murdered your name, Umadevi, please correct me. Veronica, is this the first time? Marisol, am I doing enough? That's really great. Thank you. How will they be after they go home? Umadevi, good. I got it. I can read. I passed first grade. Um, all of these questions are important questions. The problem is we can't predict future suicides. Oftentimes we have been trained classically through the medical model that by doing a risk assessment, we'll be able to predict, is this person going to do it or not? And that's a fallacy. We now know, as of 2017, Franklin and colleagues published an article, a meta-analysis, 2019, Brad Belcher and his colleagues published an article looking at all the systems of prediction that we have, and we can't predict future suicide. So this is actually good news because it means the purpose of a risk assessment should not be to predict what's next, but rather as a sort of a needs assessment. What is this person's precise needs and what resources do I have in the community or in the medical neighborhood to marry up with this person's needs? In a way, this should decrease stress and anxiety. Pucker factor goes to zero because what it means is we're not responsible for predicting what's going to happen next. And frankly, this person's life is not on our hands. And that's the toughest thing about working with individuals in suicide is that we tend to, whether it's by our Hippocratic oath, whether it's by sort of our heart and intention, why we entered the medical field or mental health field, we want to be as helpful as possible. So when working with suicidal individuals, one of the most important mental shifts we need to make is to understand that we can't make this person live or want to live more than they do themselves. And so our role is not to keep them alive. Our role is to follow the standard of care and the clinical research. So the standard of care is what the legal system says, here's the bar that you can't go beneath. Anything beneath this bar would be considered malpractice or irresponsible. But then the clinical research tells us precisely what to do that is above that bar. So we're going to go over that in a few minutes. One other aspect here that is really critical for us to explore is people's clinical style. We've all got our own interpersonal style. Again, we come from different walks of life. But in general, within the medical and mental health systems, we see three different styles. One, and this is by far the most common, better safe than sorry approach. Then we see a cavalier approach. And what we're trying to help people learn is the accurate approach. So the better safe than sorry approach sounds like this. I don't want to see anything happen to this person. Let's see if we can give them a safety plan, send them to the hospital, and we'll keep them safe. I don't want to take any risks with this person's life. Now, let's be clear. This is fairly heavy-handed. It may be very maternalistic or paternalistic. It also may be to mitigate one's own risk of losing their license or having a malpractice suit. Put a yes in the chat box if you know anybody who's been hospitalized for suicidal symptoms. Okay, I'm seeing lots of yeses. And now I'm going to ask you a true or false question. The majority of people I know who have been hospitalized for suicidal thoughts had a great experience in the hospital. True or false? Let's see what we get. This is an empirical question. Okay, so every single person who responded said false, and that's pretty common. Now, I have to be fair and reasonable here. Some people do have a positive experience in the hospital. Sometimes it's because they realize, oh my gosh, there are some very sick people here, and this is not me. So I need to do something different in my personal life because I thought I was at my wit's end and sort of at the end of my rope, but it could be a lot worse, and that's not meant to be derogatory. That we have talked to people who are patients in psych institutions, and that's how they feel. Sometimes we see a positive experience because it's an academic medical center, there's a research study going on, there's some sort of extra programming that's happening. And oftentimes, this is in the child and adolescent behavioral health units, but by and large, especially with adults, it's a negative experience. So when I have to go to the ER first and sit there for 18 hours before they can find a bed for me, and then I'm hospitalized for, by the way, what's the average duration? 72 hours. And then I'm returned back home without getting any real treatment, we're basically putting our patients through a very uncomfortable system only to return them back to the stressful environment that produced their crisis moment and their distress. And so if patients have that negative experience, they're not raising a flag in the future. They are not saying, yes, I'm thinking of killing myself, because they frequently fear being sent back through this uncomfortable cycle and this uncomfortable system. Not to mention, we've taken their autonomy in many ways. If they are obviously, if they're involuntarily hospitalized, we've usurped their autonomy. But even if they voluntarily go, it's not pleasant in some of these units where they take your shoelaces, your belt. You're in sort of a room that is very sanitized. You get the picture. So we are unintentionally punishing help-seeking behavior in the long run. Okay, so longitudinally, we are unintentionally punishing help-seeking behavior, which maintains the level of risk in our community. We've been playing that better safe than sorry short game for a half a century, and it's not working for us. We've got to start playing the long game. And the long game is over here on the right. Before we talk about how to play the long game, let's talk about the cavalier approach. This is most common in rural and frontier states. What we'll see is that they won't screen or they won't ask the question. Oftentimes, they're following the U.S. Preventative Services Task Force recommendations that if you don't have a robust treatment protocol, you can't just go screening for everything universally. And that has a lot of merit. But in some of the places where I work, like Wyoming and Montana, Utah, Idaho, you don't have a doctor for 150 miles, let alone a mental health professional for, let's say, 200 or 300 miles. And so often in these environments, the medical team won't ask at all unless the patient volunteers that they're suicidal. And obviously, in the long term and at a community level, at a system level, many people are walking around with their distress and their symptoms unaddressed. So what we're looking for is this accurate approach where we are empowering the patient to help themselves. We're not being overly heavy-handed, and we're developing mutual trust. Make no mistake that the factor that jeopardizes our trust with patients is typically our fear of losing our license. And so that's what drives us to be heavy-handed or maternalistic, paternalistic. There's nothing within the research that says by hospitalizing people, we have reduced suicides longitudinally. And in fact, only at the end of last year, Craig Bryan and colleagues published a study showing that they could reduce subsequent suicide attempts by about 41% by doing an actual treatment protocol within these psychiatric hospitals. But that's one of the only studies of its kind. Typically, there is no robust research showing that hospitalization itself reduces either suicide rates or reduces suicidal thoughts and feelings. What it does do is removes the opportunity for someone to attempt. And so in that sense, there are some people who are very appropriate for hospitalization. But looking at the contemporary research, the majority of people, we probably should think twice before hospitalizing someone. In fact, if we can put someone on the buddy system, and that's not That's not a joke. People don't usually kill themselves around others. So if I can have a good friend or family member stay with the person in distress, we know that that heightened suicidal mode is not going to stay on longer than 72 hours. In fact, it goes in waves. It might come on and off over a 6-month period. And during those heightened periods, if we can teach people to reach out for support and self-help and to have the accountability of someone else staying with them, we're much more likely to maintain their autonomy, their dignity, and they're more likely to seek help in the future because that's a much more adaptive help-seeking response than having someone sort of send you on your way to the ER and subsequently the hospital. So what we're looking for is if we follow the research more closely, we get a positive patient experience. And as a result, in the long term, we get future disclosure rather than future non-disclosure. Okay. We talked about this in a roundabout way. I'm not going to sort of rehash these stats. We do know that 1 in 4 people kill themselves in some studies. It's been shown that 1 in 4 people kill themselves within the first 7 days. If you're familiar with the HEDIS metric, that patients who have been psychiatrically hospitalized need to be evaluated within the first 7 days of coming out of the hospital, that's why, from studies like that. So suicide is not any of these things. I think oftentimes, whether it's pop culture, whether it's the culture of working in very intense psychiatric environments, whether it's a residency, a rotation, if you're a med psych type of training program, we might start to think that these things are characteristics of suicide, and they're not. Suicide is very much a state of hopelessness, feeling like a burden, feeling powerless, and feeling like you desperately want to belong but are being shut out. At the end of the day, what's so important that we should appreciate about suicide is it's not a state of indecisiveness. It's not this crossroads where the person is thinking, do I choose life or death? But rather it's a state of ambivalence. They really, really want to live and they really, really want to die at the same time. Now, any of you who are trained in motivational interviewing or who are motivational interviewing nerds like me know that ambivalence is a part of one of the stages of change, the Prochaska and Di Clemente stages of change, right? It's present in contemplation. So this is very logical. When someone's contemplating suicide, they're grappling with ambivalence. And so if you are trained in MI and you use it, that is probably the sharpest tool in your toolbox to help suicidal individuals. Let's pan back for a minute, whether we're talking about a patient in clinic, whether we're talking about someone in your family or your friend circle, or whether we're talking about a coworker. If you ask that question and they say, yes, I am thinking of killing myself, what typically happens is they unload a whole host of negative life experiences, negative feelings, negative thoughts. They really paint this dim picture of their future. What we as the helpers have to remember is that if they're talking to us, they are by definition ambivalent. People who are suicidal and ambivalent are dead already. They're not engaging in a conversation about this. And so while it can be so overwhelming for us, again, whether it's in a clinical setting or our personal life, it can be so overwhelming to hear someone we love or someone we're trying to take care of talk about suicide. We have to look at their behavior. If they're still alive and they're willing to talk to us, by definition, they're ambivalent. And we have to rest assured that there is some spark that wants to live, or they would not be talking to us. Oftentimes it's helpful to educate them about this state, to say, you know, what we know about suicide is that most people who think about it don't really want to die. They just don't want to live with their pain. Is that how you feel? Now, I know that goes against some of what we've been trained. It is a bit of a closed-ended question, but it is important because we have to give them some sort of scaffolding to hang their experience on. Right? We've got to give them something that relationally they understand, because for many people, this moment of feeling suicidal is a foreign experience. So, another way to say this is, if we could take away everything going wrong in your life, would you still want to die? Most people say no. because they're ambivalent. The only reason they want to die is because life is so miserable. But if life wasn't so miserable, of course they would want to live. And it's so critical that we talk about ambivalence, because this, just like with motivational interviewing, is a place where we meet them where they are rather than where we want them to be. And then we empower them to work through the thought processes for subsequent change. Just a sort of a tip here, please try to avoid these terms. They are not empirically based. They're not universally operationalized. In fact, the ones on the left, oftentimes we hear those just coming out of casual conversations in multidisciplinary teams. So a team where, let's say, I'm just going to pick on a few people in the chat box here. Let's say Vanessa's the physician, Liliana's the psychologist, and I'm the nurse. And we're talking about how Mrs. Jones attempted suicide last night. And Vanessa says, yeah, but it was just a suicide gesture. And Liliana and I say, yeah, you're right. It was just a gesture. So what did we just do behaviorally when we labeled it a gesture or labeled it a threat? Put in the chat box or unmute your mic. What did we just do? Ellie says we dismissed it. Does anyone else have a suggestion? It was just a threat. From a multi-D treatment perspective, what have we just done? Judgment. Yeah, we've judged it. That's great, Liliana. Don says we made an assumption. Absolutely. Underestimated how the patient feels, minimized it, downplayed it. That's great. Invalidated the person. That's great, Marisol. At the end of all of those are correct. And the product of all of those is that we reassure ourselves that doing nothing different for the treatment plan is the right way to go. And that's not reasonable, because if we see a behavior or a thought recurring, then we've got to lean in and figure out why we haven't decreased its frequency or decreased its duration. So consider not using these. The reason why we avoid on the right side here the word commit is because it's stigmatizing. Because typically within the fabric of our culture and society, people commit sins and commit crimes. If unless you hear lots of people talking to their friends, hey, I'm thinking of committing this, I'm thinking of committing that, those words joined together don't really work. And so it's very judgment laden and value laden. And what we know is that it's a deterrent for someone who's in distress to say, hey, I'm struggling with suicidal thoughts, because they're not going to admit that they're thinking of committing something. I'm using lots of air quotes today for some reason. Must have had a lot of coffee. So moving upstream, just by way of comparison, if 12.3 million people think about suicide every year, and it's a social issue, remember, it's just what happens when we get overwhelmed. The majority, 99%, will never die by suicide. Maybe this is just a safety issue, and we need to talk about it in the same way we talk about stranger danger or look both ways before you cross the street. Fire safety. I mean, when I was a kid, the number of times stop, drop, and roll was pounded into my head. I was convinced I was definitely catching on fire at least a dozen times in my life. Okay. Now, thankfully, I have not caught on fire ever, but I still remember stop, drop, and roll, and I think maybe we can all relate to that if we grew up in a similar culture, similar environment. But it's this age of 5 or 6 that we want to start talking about this. And again, I say this whether you are seeing peds in your family practice, whether you are interested in going to pediatrics, whether we're talking about our own families. Now, how do we have that conversation with a 5, 6-year-old? It's the same way we do with these other complicated, difficult topics. We make it developmentally appropriate. And of course, at that age, children are much more focused on their peers than they are insightful about their own thoughts and behaviors. So we say things like, hey, Johnny, if any of your friends ever talk about wanting to die or wanting to kill themselves, come tell, mommy or daddy, come tell your parents. You won't get in trouble. We just want to keep your friends safe. So that remember, that's the age where they're tattletales. Let's leverage that developmental phase. They're not angels. I mean, they don't always do what they're supposed to do, but they are tattletales. Johnny's picking his nose. Susie did that, right? why aren't we leveraging this cultural trend and this developmental period of theirs where they are very black and white? Um, so again, it's because of stigma and because most of us as parents were not taught about this or taught to talk to kids about this. And then as they get older, perhaps closer to that 9, 10-year-old age where we do start to see some attempts, we say, hey, if you've ever had those thoughts, come tell us. We're not going to get you in trouble. We just want to make sure your life is happy for you. We don't want you to be living, an unhappy life. So if you're if this talk to up till now, and I've got about 15 minutes, 14 minutes, if this has left you wondering, okay, this is all great, Kent, but give me some nuts and bolts that I can use in clinic. Uh, these are the 5 skills that we recommend in Prosper. If they look very similar to the Columbia Suicide Severity Rating Scale, it's because functionally they accomplish the same thing. We were publishing this at the same time they were publishing their instrument. So if you like inventories, the CSSRS is a wonderful one. If you're not familiar with it, I'll go through these very quickly. So there's a difference between suicidal thoughts and death thoughts. If 12.3 million people think of suicide at least once a year, probably 5 times that have death thoughts. Death thoughts are just that state of being completely overwhelmed. If you've gone to med school, grad school, you've had death ideation. If you've gone to basic military training, police academy, fire academy, you've had those thoughts. If you've had a child, that first 24 hours of being home with the new baby, you've had death thoughts. It's like, I am not sleeping. This is awful. This doesn't seem like life. What is going on? I just wish I could go away. It's a very common human experience, and it's actually much lower in terms of risk. That is to say that people who think about DI, it doesn't reliably result in suicidal actions. Now, it can grow into suicidal thoughts. And the main difference is they're both escape-oriented mindsets, but with suicidal thoughts, I'm actually thinking that I might play a role in ending my life. Whereas with death thoughts, I'm just thinking of dying so that I could get away from my pain. The second skill is prior suicide attempts and behaviors. Behaviors are things like plans, preparation, rehearsal. So choosing what firearm I'm going to use. Do I want to put it to the top of my head, to my temple, under my chin, in my chest, right? Again, these are details not to traumatize you, but to help you understand that there's a significant amount of thought among that 80% about how this is going to work and how we prepare to do this. Like any other set of symptoms, we want to assess the current episode by asking about frequency and duration. How many times have you thought of killing yourself in the last 2 weeks? Once a day, once an hour? And when you are thinking about it, how long does it last? 5 seconds, 5 minutes? Then we think about thoughts and desires versus actual plans, preparation, and rehearsal, with the plans and preparation and the behaviors being much more indicative of higher risk than just people who think about it or want to die. Next, we educate people about ambivalence, the way we talked about a few moments ago. And that is really our sort of our stepping stone, especially using MI, motivational interviewing, to talk about reasons for living and reasons for dying, right? And what we know is that if someone's suicidal mode is on, when we talk about reasons for living, it tends to turn that suicidal mode off. So this is a critical point in our discussion. We talked before about how you might see someone in clinic who reports suicidal symptoms, and we have to determine, is their suicidal mode on this very second or off? If it's off, we go through this quite easily. If it's on, we're going to struggle until we get them to identify reasons for living. And that usually deactivates the suicidal mode and helps sort of de-escalate them. It's not that it can't turn back on, but it helps them think more logically. And that reasons for living part is sort of the pivot from assessment to intervention, because the intervention is, of course, helping them learn a crisis response plan. We can go into detail about the differences between safety plans and crisis response plans. There are functional differences, which is really important. They tend to be structured almost the same, but they are functionally different. There's a study, again, coming out of Craig Bryan's shop at Ohio University. Justin Baker is the author, talking about how patients prefer crisis response plans to safety plans and actually use them more. And of course, a crisis response plan is just a clinical word for a self-help guide. It's a let me go to the next slide. It is sort of a list of the warning signs, what I can do to manage my symptoms, reiteration of my reasons for living and actually prescribing myself ways of engaging in those reasons for living. People who I can reach out to for social support. And that doesn't mean I need to tell them I'm suicidal. It just needs to be that I'm not alone, that I'm putting myself in the presence of others. Then, of course, crisis and professional services. And finally, lethal means management. So lethal means management means asking them about access to firearms or ligatures or sharp objects, chemicals, over-the-counter meds or prescription meds. We do know that 53% of suicides in America are with a firearm. 29% are with some sort of what's called suffocation. So whether that's using a ligature, whether that's putting your car on in the garage and breathing in the carbon monoxide, putting a bag over your head. That's the second most common way that Americans kill themselves. Going back for a moment, I'm not going to read these, but if we truly want to follow the evidence-based research, we can't try to approach people with a protectionist approach. It's got to be an empowering approach. So saying things like, you know yourself best. What do you need right now? You know yourself best. Who can you rely on for social support? You know yourself best. What are your warning signs? So really encouraging people, acknowledging their autonomy, making sure that that nothing's going to happen without their permission, and that includes hospitalization. The only people we hospital are typically people who cannot complete a crisis response plan. When they complete their crisis response plan, they don't feel confident with it. In a very motivational interviewing way, we might use those scaling questions and say on a scale of 1 to 10, 10 being the most confident you've ever been about anything, how confident are you that you can use this? So that, again, that comes in handy. Just a footnote here as I wrap up. If you want more information about this, here's our website, prospertogether.net. Now, what I will share is that the website is actually down today because we are launching a new website. So the time is not convenient, but I'll throw that out there again. If you're interested in checking out our website, do that in I don't know, 2 days or so. As we wrap up, panning back again from clinical. Yeah, thank you for that, Dr. O. Please put any questions you have in the chat box. As we pan back from the clinical and try to think about helping coworkers or those we supervise, leadership is important. Leadership goes a long way in making a situation safe so that people can seek help. I did for the last 3 years, I was the suicidologist for U.S. Customs and Border Protection. It's a 65,000 person federal law enforcement organization. And skipping to the third bullet here, I can tell you there is not a lot of psychological safety there. And what that means is it is not safe for someone to point out something wrong versus that something feels bad. The culture just doesn't tolerate it well. If you're interested in reading about psychological safety because you are maybe a residency director or chief resident or someone who is able to improve organizational culture, whether that's at work or at home in your family, there's a great book by Amy Edmondson called The Fearless Organization. And she's an incredible, a prolific professional who has really researched psychological safety and how we can create that in work settings. At the end of the day, we also, as coworkers, can help compete with our coworkers' reasons for dying. If we just assume for a moment that 2 or 3 people we work with are suicidal, then we can compete with reasons for dying by making work a place where people want to be. Again, we can't control whether people live or die, but we certainly can work on the environmental factors that make them want to live more. Here are some suicide and crisis resources. I'll leave this up as we answer a few questions. Uma Devi says, what exactly makes a CRP and safety plan functionally different? That's a great question. So the CRP is much more of a self-management strategy that can be used upstream, whereas the safety plan is sort of used when someone's in crisis. So longitudinally, if we, let's say I'm thinking of suicide right now, so I take out my safety plan or crisis response plan and I follow it. The CRP, how people use the CRP tends to be more like self-help. The way people implement a safety plan tends to be more like a safety net. So sort of like if you go into crisis, use this sheet. And it's sort of Sometimes it's even done in an administrative capacity rather than an intervention. If you ask most physicians and even mid-levels and mental health professionals what treatments they've been taught for suicidal ideation, they don't have them. They haven't been taught that. In fact, only 50% of graduate programs in mental health in America formally teach suicide management. And so the interventions aren't a safety plan that gets you to 911. The interventions are a CRP that help you think of things that you want to live for, engage in those reasons for living, so that when you're not in crisis, but you're in a stressful situation, you use that same strategy. And then you learn to take it upstream. And when a stressor happens in life, you use those same strategies. So a CRP just over time teaches healthy coping. A safety plan is sort of what to use only at that crisis moment. That's a really good question. Thanks, Dr. O, for putting the book in the chat box. Maria, when assessing confidence with a crisis plan 1 to 10, acceptable range, we use the standard range. I don't believe there is any research showing what that is, so we're extrapolating from the MI research. And if they answer 7 and above, we kind of err on the side of it's the likelihood that they'll use it. Lastly, if you want to join us on social media, we're always looking to build communities. The last sort of thing I'll say about this is that connectedness reduces suicide risk. And that's the type of prevention we can do every day in every aspect of our lives. So whether it's connecting with family, whether it's having family dinner once a week or more, whether it's connecting with your fellow residents or coworkers, colleagues, and doing something regularly, that connectedness reduces risk. And we have to keep thinking of reducing risk in the long game, not the short game. If you'd like to connect with us on social media, there we are. And I think I've got 3 more minutes if anyone has questions. Oh, I should put up our references. I think they're in 0.2 font. Thank you so much for your engagement. It's great working with you all, and great to see some friends from long ago. Oh, let me put my email in the chat box if anybody wants to reach out and say hi. Let me give you that information.
While he's doing that, I just want to say again, thank you, Dr. Corso, for your fantastic presentation. As people are also putting in the chat box their thank yous, please, folks, fill out the evaluation that Catherine has placed in the chat box so we can gather feedback from today's talk. And again, thank you, Dr. Corso. Take care, everybody.
I
Bye.
can't.
Take care, guys. Good to see you, Cindy, Don, Stacy.
Bye, Kent.